Welcome to Part 2 of the Salvation Protocol. Part 2 describes evaluation of afterload and preload in hypotension and hypoxia. Let's look at afterload evaluation first. When evaluating afterload, we will evaluate conditions that cause increased RV afterload, which in turn leads to systemic hypotension. We will also review echo features of low SVR such as sepsis. Common causes of increased RV afterload include pulmonary hypertension, RV failure, acute fluid overload, and pulmonary embolism. We can use all four echo windows to assess the RV. It is important to remember the ventricular interdependence between the left and right ventricle. This is best appreciated in the parasternal short axis view, where the interventricular septum can be visualized. The parasternal short axis view is obtained with the probe in the third or fourth left parasternal intercostal space, with the transducer marker facing the left shoulder. Let's look at a normal LV and RV in the PSAX view. The LV contracts well, and the RV is normal in size. The interventricular septum is normal in shape and the LV cavity is circular in end diastole. The end diastolic and end systolic areas of the LV appear normal. The LV walls thicken equally in all segments, and the LV cavity reduces in size circumferentially during systole. Let's now look at increased RV afterload. Here we have a significantly dilated RV. The interventricular septum is flat during diastole. This gives the LV a D-shaped appearance in diastole. The elevated RV pressure in end diastole exceeds LV end diastolic pressure and causes the interventricular septum to be pushed into the LV. This in turn impairs LV filling. We can look at a still frame here. The LV is clearly D-shaped in diastole, and the cavity is reduced in size. These appearances are typically seen in increased RV afterload conditions such as pulmonary embolism. Other important signs of pulmonary embolism include McConnell's sign, where there is hypokinesia of the RV free wall with apical sparring. Other signs seen in acute RV afterload increase include plethora of the IVC and decreased respiratory variability of the inferior vena cava. This is seen here. The IVC appears full, and there is no change in caliber with respiration. We can go on to scan the lower limbs for evidence of deep vein thrombosis in patients where pulmonary embolism is suspected. A linear probe can be used for compression of the femoral and popliteal veins. The veins are compressed with the transducer in the transverse plane. Failure of the anterior and posterior walls to touch each other during compression leads one to suspect the presence of deep vein thrombosis. The femoral vein is compressed just distal to the inguinal ligaments. In pulmonary embolism, there is acute pressure overload due to mechanical obstruction of blood flow from the RV. This causes the RV pressure to exceed left ventricular end diastolic pressure, which in turn leads to flattening of the septal wall. The LV cavity becomes D-shaped in diastole, and LV filling is impaired. To summarize, the echo features of pulmonary embolism are dilated RV, septal flattening, and a D-shaped LV. McConnell's sign is highly specific for pulmonary embolism, and can be described as hypokinesia of the RV free wall with apical sparing. Check the leg veins for features of inability to compress the veins. Failure to compress the veins has a high index of probability for the presence of deep vein thrombosis. Other important causes of afterload problems include large atrial tumors such as atrial myxoma and systolic anterior motion of the mitral valve. These are obstructive causes of hypotension. We can now consider reduced afterload as a cause of hypotension. The common causes of decreased afterload include distributive shock such as sepsis and anaphylaxis. In conditions of reduced afterload, the key echo features include kissing ventricle and a hyperdynamic LV. The left ventricular diastolic volume is normal while the LV and systolic volume is reduced, causing the ventricular walls to meet in systole. An example is shown here. The LV on the left is normal, while the LV on the right is typical of patients with low afterload. The LV is hyperdynamic, and the end systolic volume is small. The cavity of the LV is small in end systole. We can now look at preload reduction and echo features of low preload. Common causes of preload reduction include hypovolemia from any cause such as hemorrhage or fluid loss. Other causes include large collections in the pericardial, pleural, or peritoneal space. Tension pneumothorax is another cause. Finally, we can use echo to evaluate the abdominal aorta for any evidence of dissection or rupture. Here is an example of an LV in a patient with hypovolemia. In hypovolemia, both the end diastolic and end systolic volumes are reduced. The ventricle has the appearance of a kissing ventricle at end systole. This is in contrast to low afterload where the end diastolic volume is normal. Note the small size of the end systolic LV cavity in the image on the right. When making an assessment of volume status, we can also look at the inferior vena cava. A small caliber IVC with respiratory variation greater than 50% is indicative of hypovolemia. The IVC diameter should be measured 2 cm distal to the RA-IVC junction. The next slide summarizes the findings in hypovolemia compared to low afterload. Both conditions are associated with a kissing ventricle, however in hypovolemia, the end diastolic volume is reduced. In afterload reduction, the end diastolic volume is initially normal, and only becomes reduced in advanced stages of low afterload. When making an assessment of preload, we can incorporate the FAST protocol into scanning. For further views are used, these are the IVC view, left and right upper quadrant views, and the pelvis view. The IVC view is used to evaluate IVC caliber and respiratory variability. When evaluating the upper quadrants, we use the curvilinear probe. The right side involves evaluation of the liver, right paracolic gutter, costophrenic recess, and right kidney. On the left upper quadrant, we evaluate the left paracolic gutter, costophrenic recess, left kidney, and spleen. Moving the probe to the pelvis allows evaluation of the rectovesical pouch in males, and the rectouterine pouch in females for free fluid. The abdominal aorta can then be evaluated for evidence of rupture or dissection. This is performed by obtaining the aorta slide views. The curvilinear probe is slid from the subxiphoid position past the umbilicus to the pelvis. This allows the length of the descending aorta till the bifurcation into iliac arteries to be assessed. A normal aorta measures less than 3 centimeters. An aortic diameter larger than 5 centimeters warrants consideration of acute rupture. In Part 1 of the Salvation Protocol, we looked at evaluation of contractility when making an echo assessment of the hypotensive patient. In Part 2, we have looked at afterload and preload assessment. Part 3 of the Salvation Protocol will look at the lung views used in evaluation of hypoxia. Thank you for watching this tutorial.